When a parent notices a slight yellowish tint to their newborn's skin, it's so often brushed off, right? Just a harmless little phase, a totally natural part of waking up to the world. But neonatal jaundice, or neonatal hyperbilirubinemia, if we're being clinical, is actually this incredibly complex, high-stakes metabolic balancing act happening right inside that tiny vulnerable infant. We're diving straight into exactly what drives this condition, how to manage it, and precisely when it crosses the line into a life-threatening emergency. Because what looks like a simple change in complexion on the outside, it's actually a desperate cellular struggle on the inside. Think about this for a second. Up to 60% of full-term infants and a massive 80% of preterm infants develop clinical jaundice in their very first week of life. 80%. That is not some rare medical anomaly. It's quite literally one of the most common conditions affecting newborns globally. And honestly, because it's so incredibly common, it's super easy for caregivers to underestimate the risk and just assume, oh, it'll clear up on its own. But understanding exactly what is happening under the surface is absolutely crucial. The line between a normal physiological adaptation to life outside the womb and a catastrophic, life-threatening crisis is incredibly thin. We really have to know exactly what we're dealing with. So what exactly are we looking at here? Clinically, neonatal jaundice is defined as the yellowish discoloration of a newborn's skin, their mucous membranes, and the sclera, the whites of their eyes. But here's the thing, that yellowing is really just the visible alarm bell. What's actually happening is this invisible internal metabolic backlog. There's an elevated concentration of a waste product called bilirubin circulating in the baby's blood. To understand exactly why this dangerous backlog happens and why bilirubin builds up in the first place, we've got to look closely at the baby's blood itself, specifically how a newborn's body processes its own red blood cells immediately after birth. Let's trace this step by step because the biology is actually fascinating. First off, newborns have this super rapid turnover of red blood cells. While our adult red blood cells live for about 120 days, a newborn's cells, they have a lifespan of only 70 to 90 days. This happens because they're quickly transitioning away from fetal hemoglobin to adult hemoglobin. When these fetal cells break down, they release hemoglobin. That hemoglobin gets metabolized into a byproduct called heme, which is then converted into something called unconjugated bilirubin. Now here's the catch. This unconjugated form is fat-soluble. It can't just easily be flushed out of the body in water or urine. It actually has to bind to a protein called albumin, which acts like a little transport vehicle to carry it through the bloodstream directly to the liver. Once it finally reaches the liver, an enzyme converts it into conjugated bilirubin, making it water-soluble. Only then can it be safely excreted through bile into the intestine and eventually leave the body in stool. And this brilliantly illustrates the central problem. The crucial bottleneck in this entire system is the newborn's liver. Specifically, a newborn's liver relies on enzymes like UGT, which basically acts as the main chemical processing plant. But in a newborn, these enzymes are simply immature. They just aren't fully up to speed yet in those early days. So you have this massive influx of rapidly breaking down red blood cells crashing into a liver that is processing them at a fraction of the required speed. This leads to dramatically reduced bilirubin conjugation. That unconjugated, fat-soluble bilirubin has literally nowhere to go, so it temporarily and dangerously accumulates in the blood and binds to the surrounding tissues. The crucial point in care is knowing when this accumulation is just a normal adaptation and when it's a full-blown medical emergency. Clinicians draw a hard, distinct line between two categories: physiological jaundice and pathological jaundice. Physiological jaundice is the benign type. It appears after the first 24 hours of life, usually peaking around day 3 to 5 for term babies, and the baby otherwise appears perfectly healthy, feeding and acting normally. But pathological jaundice, that is an abnormal, aggressive spike that appears within the very first 24 hours. The bilirubin levels rise incredibly rapidly, breaking all normal growth curves. And let me be clear, this always requires urgent medical intervention. So why does pathological jaundice happen so incredibly fast? Well, because it's driven by underlying illnesses or trauma, not just a slow, immature liver. Pathological jaundice is a massive red flag. We're talking about causes like hemolytic disease, where the baby's red blood cells are actively being attacked and destroyed. This very often happens due to blood group incompatibilities, like when a mother and baby have clashing Rh or ABO blood types. That causes the mother's antibodies to literally cross over and break down the baby's blood. Other triggers include genetic enzyme deficiencies like G6PD, severe systemic infections like neonatal sepsis, or even birth trauma like a cephalohematoma. That's bleeding under
the scalp, often resulting from forceps or vacuum deliveries, which forces the newborn's body to break down an enormous pool of trapped red blood cells all at once.
Now, there is also a very common area of confusion that we absolutely need to clarify: the role of feeding. There are actually two entirely different types of jaundice related to a mother's milk. First, there's breastfeeding jaundice. This happens in the first week, and surprisingly, it's actually caused by a lack of milk. If the baby has poor feeding, inadequate intake, or dehydration, they simply don't pass stool, known clinically as meconium, frequently enough to physically flush that bilirubin out of their system. On the exact flip side, we have breast milk jaundice. This begins later, usually after the first week. In this case, the baby is feeding wonderfully, but specific substances naturally present in the breast milk actually increase the reabsorption of bilirubin back through the baby's intestines. In this scenario, the baby is thriving, and breastfeeding is generally continued safely. To keep this whole clinical picture crystal clear, we can actually systematically drop every single cause of jaundice into 3 functional buckets. Bucket 1, increased production. This is your ABO incompatibility or birth trauma, where simply way too many red blood cells are breaking down at once for any system to handle. Bucket 2, decreased conjugation. This means the liver isn't processing what's already there, often due to extreme prematurity or conditions like congenital hypothyroidism. And bucket 3, increased enterohepatic circulation. This simply means the bilirubin gets successfully processed by the liver, but because of delayed feeding or intestinal obstructions, it sits in the gut way too long and gets reabsorbed back into the bloodstream before it can even exit the body. So how do nurses and doctors actually visually track this escalating threat at the bedside? They watch for what is known as cephalocaudal progression. It's this fascinating yet frankly terrifying pattern of spread. The yellow discoloration literally travels downward as the severity of the toxicity increases. It almost always starts right on the baby's face. Then, as serum bilirubin levels climb higher in the blood and bind to deeper tissues, the yellowing spreads down to the chest, then covers the abdomen, moves down the legs, and in the most extreme, dangerous cases, it actually reaches the palms of the hands and the soles of the feet. This downward visual mapping is an absolutely crucial, immediate assessment tool.
But look, visual assessment is never enough on its own, right? We need exact, quantifiable numbers to build our diagnostic picture. So hospitals will run rapid-fire laboratory investigations to measure the exact threat level. They pull blood to check total serum bilirubin, specifically breaking it down into direct and indirect levels to see exactly where that liver bottleneck is occurring. They immediately check blood group and Rh typing for both the mother and infant. They also run a direct Coombs test, which specifically looks to see if maternal antibodies are actively attached to and attacking the baby's red blood cells, alongside a complete blood count and a peripheral blood film to check the overall structural health of the cells. Once we have those exact numbers, expert medical management kicks into high gear. And the frontline treatment is just incredibly elegant. Phototherapy. Now, this isn't just regular room light or sitting by a window. This is a highly specific wavelength of blue light designed to penetrate the baby's skin. Remember earlier how we said unconjugated bilirubin is fat-soluble and trapped until the liver processes it? Well, this blue light acts as a biological workaround. It physically alters the shape and structure of the bilirubin molecules right there in the skin tissue, converting them into water-soluble isomers. This means the toxic bilirubin can be easily flushed out in the urine and stool, completely bypassing the need for the baby's immature liver to do the heavy lifting.
But applying this blue light requires some seriously meticulous, round-the-clock nursing care. To get the absolute maximum effect, the infant needs maximum skin exposure, so they wear nothing but a diaper in the incubator. Now, this can be deeply emotional and scary for parents to see, but it is entirely necessary. Because the intense light can be damaging to the delicate retina, their eyes must be carefully protected with specialized ocular patches. The baby is manually repositioned every 2 hours to ensure even light exposure across the skin. And because lying under these intense lights with so much exposed skin can lead to rapid fluid loss and overheating, nurses are constantly monitoring the baby's core temperature, checking for dehydration, and aggressively encouraging frequent feeding to flush out those newly water-soluble bilirubin molecules.
Sometimes, however, the bilirubin rises so aggressively that phototherapy simply cannot keep up with the backlog. When phototherapy fails, or if there is severe hemolytic disease actively destroying blood, we have to move to a critical emergency procedure, an exchange transfusion. This is exactly what it sounds like. Medical teams use an umbilical catheter to physically remove the toxic bilirubin-soaked blood from the baby's body in small increments and replace it with fresh, healthy donor blood. Not only does this drastically and immediately drop the circulating bilirubin levels, but it crucially removes those harmful antibody-coated red blood cells that are causing the rapid breakdown in the first place.
Now, in highly specific cases, namely severe R or ABO blood group incompatibility, there is another specialized tool in the arsenal: intravenous immunoglobulin, or IVIG. Instead of just treating the resulting bilirubin accumulation, IVIG goes directly after the root cause of the incompatibility. By introducing concentrated proteins, it effectively gives the maternal antibodies a different target. It basically distracts them and stops them from binding to and destroying the baby's red blood cells. By halting this active hemolysis, IVIG can often stabilize the baby and prevent the need for an invasive exchange transfusion entirely, giving the newborn's liver that crucial time it needs to catch up.
Of course, the reality is most jaundice management doesn't happen in the neonatal ICU. It happens right at home. Empowering parents through highly detailed health education is a massive part of newborn care. Caregivers are given very actionable daily tasks. They need to breastfeed 8 to 12 times a day to ensure the baby is adequately hydrated and passing stool to actively excrete the bilirubin. They must track urine and stool output carefully. But perhaps most importantly, we must emphatically debunk a really dangerous lingering myth. Parents should never substitute actual medical evaluation with putting their baby in direct sunlight. I know this comes from old medical advice based on different window glass types used decades ago, but it is completely wrong today. While sunlight does have some blue light, it absolutely does not contain the concentrated wavelengths needed, and placing a naked newborn in sunlight poses massive immediate risks of severe sunburn and hypothermia. Parents are also taught to aggressively monitor for the absolute red flags. These are the clinical signs that the jaundice has escalated and the toxic bilirubin has actually crossed the blood-brain barrier. If a baby develops a fever, outright refuses to feed, or becomes excessively, unnaturally lethargic and sleepy, it is an absolute emergency. Even more terrifying are the advanced neurological signs of brain involvement: a sharp, high-pitched cry, sudden convulsions, or a condition called opisthotonus, which is the severe, rigid arching of the baby's back and neck. These signs are absolutely not to be monitored at home. They mandate an immediate, sirens blaring rush back to the hospital. You might be wondering, why are clinicians so incredibly aggressive with these protocols? Well, it's because the consequences of ignoring pathological jaundice are grim, and they are totally irreversible. If toxic levels of unconjugated bilirubin penetrate the brain tissue, it causes a condition known as acute bilirubin encephalopathy. If that cellular damage becomes permanent, it is known clinically as kernicterus. This leads to devastating, life-altering outcomes for the child: permanent hearing loss, severe cerebral palsy, profound intellectual disabilities, and tragically, in the most severe cases, death. This is exactly why early detection, meticulous tracking, and expert management are absolute non-negotiables in newborn care. So we've seen the precise biological bottleneck that causes this dangerous accumulation. We've mapped how quickly it travels from the head right down to the toes, and we've explored the brilliant medical interventions, from targeted blue light to complete blood exchanges, that bypass an immature liver to quite literally save a life. But the margins for error here are incredibly thin. Knowing how rapidly a newborn's biological backlog can tip into a lifelong, irreversible neurological crisis leaves us with a heavy, necessary thought. Are we truly doing enough to educate parents and monitor our most vulnerable patients in the absolute critical window of their first 24 hours of life? Keep that question in mind as you look at newborn healthcare moving forward.